Also, I think when you look at the savings piece, what's supposed to happen, and tell me if I'm wrong here, but essentially, if there's more efficiency in the system, and Jeff touched on this before in terms of driving out the waste, I mean, I assume if you look in a microcosm at a community like ours, a smaller community with, basically one hospital system and hundreds, if not maybe a couple thousand doctor practices and a couple different, health insurance companies and long-term care facilities and things like that, what are going to be the key drivers? So if we say there's waste in the system, the same person goes for the same medical procedure at 3 different places within a 2-year period, and because medical records aren't being shared or things like that, take us through where could some of these savings be realized, and how realistic is it really to get hundreds, if not thousands, of different organizations speaking to each other and cooperating to do it?
Well, I think there's actually a lot of opportunity for that. Now, it's not going to happen overnight. It's going to take years, probably decade. But the systems are coming in place now to start facilitating that. There's more cooperation on information sharing. There are certain things that are sponsored either out of the reform legislation or out of the stimulus package that can facilitate these things. One is, and it's something that we're working on, the hospital's working on, and some of their constituents are working on, Health Information Exchange, which is an organization that's designed to link all of the electronic medical records of the various practices together so that we can see what's going on and coordinate care. We've had conversations with the hospital about linking some of our imaging equipment with theirs, so that if a patient has a CT or an MRI or even an X-ray in our shop, that picture could be viewed at the hospital. The lab systems will come online. All of these things over time will become more and more integrated. And then another piece of the puzzle is something called the Accountable Care Organization, which is in the legislation, and it's actually one of the things that I'm most excited about. Yep. And that is where groups of providers essentially band together to look at information in a different way and actually share in some of the savings that are generated from their efforts. And I think the result of that is going to be tremendous uptick in quality, as well as tremendous downtick or bending of the cost curve. Now, here, I'll give you a little bit of an example rather than just kind of give you the clinical definition of an ACO. Imagine a group of providers that have agreed to work together to decrease costs, and you're a diabetic, but you have an orthopedic issue. When you go to the orthopod's office, because of the interlaced systems in that these providers have put together, the orthopedist staff recognizes that you haven't had a particular test that you need to have. And the orthopedist staff orders that test for you, even though it's done in a different facility, so that we can make sure that our diabetics within the population that we serve are well managed. And it becomes, because the orthopedist is a part of this accountable care organization, it becomes important to him or her that that diabetic is well managed, just as it is to that primary care that's actually taking care of them. That's a whole different ballgame. That is a whole different system. There are places across the country that are already doing this, but they're more truly integrated systems, and you hear about them from time to time. In fact, they're the ones that the president will talk about. They're the Geisingers, the Intermountains, the Theta Cares, the Mayos, the Clevelands, the Scott and Whites. All of those folks have integrated delivery systems. Well, this legislation is going to help facilitate and drive virtual integrated delivery systems, so that Jack and I and our two organizations are on the same page, and same with the long-term care facilities. And that's where a lot of this opportunity to reduce the cost comes from. And then there's other models too, patient-centered medical homes, and that's essentially getting the right people to do the right job. It's something that I alluded to earlier. Physicians don't necessarily have to see every sore throat. A mid-level provider can take care of that with the same level of quality. Let's keep the physicians in the position to make those very, very difficult diagnosis and not so much the routine things. So there is a lot of opportunity, and we can bend the cost curve. As I mentioned earlier, I'm concerned that the rate of utilization with the diabetes and the obesity and the aging of the baby boomers are going to outpace the system that can deliver it, even if we can make all of these changes.
Well, that plays right into the next question from the audience at table 38. Nikki Knotts.
I appreciate the diversity on the group. One that's missing is the home health industry, and with the decreases in reimbursements that we're all going to feel as providers, how is home health going to play a role when there are not enough institutional beds, and we all are still going to have to see those patients? We're going to have more patients in the home needing that care. We've had decreases in the Medicaid and Medicare reimbursements at every level, but in specific, the state home care Medicaid changes recently are going to impact about 30,000 local residents who are receiving care in their homes.
From a hospital perspective, clearly, I think where the accountable care organization's going, there's a penalty in the process to penalize hospitals for readmission rates 30 days out. Well, we could have the patient perfectly ready to go home, and if they don't follow their home care routine or don't follow their instructions, we get the readmission, we get penalized in the process. So, going back to what Jeff's saying, the accountable care organization, the medical home, is going to require a continuum of care. You're going to have to rely, and we talked earlier, we've got great pre-hospital, great post-hospital care in the process. We are expanding our home care business that we own and operate, or we manage through Pender and we lease through them. We are going to be involved in the home care business. We've got some great home care providers in the community, and it's going to be absolutely a requirement as we go on, because we're not going to have the acute care issues for the next 10 years once we finish our renovation that we've had in the past from a bed perspective, but the pressures to get people discharged are going to continue to grow and grow and grow as we go on. So this is going to require a continuum across the board of everybody, and we're going to have to rely heavily on all of our post-care providers, and that's going to have to be part of any conversation that we have. And they've got to be linked through the HIEs. They've got to be linked so that we can find out what's going on with the care that's being provided in the field, and they need to be able to access what's gone on within the hospital during the stay, or if someone's gone back and visited a doctor's office. One of the things that Jeff said, we've got the health information exchange. Cool thing, you come in at 3 o'clock in the morning, you can check and see what's been done in your office. Great lead to the ER doc. But we're going to have 2 systems. We're going to choose 2 systems that are going to be completely integrated into our 2 medical record systems that'll be completely integrated into our system, and we're going to choose, and then if doctors go to that, they'll be able to access everything in their records and be able to get that information. And that same information flow has got to happen with the post-acute providers and the home care providers. We have to be able to share that information down the line through the HIE.
Yeah, just to piggyback on that briefly, Nikki, I see one of the biggest cost drivers can be related to the transitions of care, and home health is definitely a connective point for those transitions of care. Some of the new regulations, although not maybe directly related to the reform, are requiring that we tighten up these transitions of care, and the information systems provided by the home health people can be absolutely instrumental in helping us make sure that we don't drop the ball on the transition pieces. So all of these pieces link together, absolutely.